Hi everyone, welcome to this new episode of Guida Galattica per Fisioterapisti podcast. Today I'm really happy to welcome on our show Amanda Johnson. Hi Amanda, how are you?
Hi Paolo, how are you? I'm very pleased to be here and thanks for the invitation.
Yeah, I'm very well, thanks. And yeah, we're really happy to have you today and to talk about youth athletes and growth-related injuries. As always, Amanda, we ask our guests to introduce themselves to our community. So if you'd like to share with us some of your background and education and professional experiences.
Okay, so I qualified over 40 years ago now, so it's been a long career, both clinically and more recently academic. Always involved in sport right from the word go. But when I first qualified, if you wanted to work in sport, you did it sort of after hours, after you'd finished at the hospital, and weekends and in the evenings, and got very little pay for it. So things have massively improved since I first qualified. So first of all, I worked with athletics and swimming because I was an athlete and a swimmer. So again, word of mouth, and people get to know you're a physio and you get involved with squads and associations. And I travelled a little bit with the England athletic squad, covering international camps and international sort of meets, and then moved over more into the swimming with junior swimming teams and synchro swimming teams, and then was asked to cover a diving tournament, the Junior World Championships, in fact, in Czechoslovakia, and I'd done a bit of diving myself, but not a great deal, but really enjoyed doing that, and they asked me to stay with the divers, and I stayed with the diving teams for 10 years. So travelled around the world at the Grand Prix circuit and European Championships, Commonwealth Games, World Championships a couple of times. So was heavily involved with the divers for 10 years, which was great fun. And in the meantime, I started work in professional football, got a job with a lower league club. So I was full-time with a lower league club, so covered the first team and the reserves team, and as anybody that knows who works in football, it's a sort of a more than a full-time job. You know, you're sort of on call 24 hours a day. But you know, it's a big learning curve, and was asked also to be the physio to the women's national team. So I was with them for 5 years, and again covering all international matches and European Championships, World Cup, etc. And then moved out of football actually and went back into private hospital and managed a physio department there. But we had a lot of professional footballers using the hospital, and then decided to improve my academic sort of qualifications, because when I qualified as a physio, we didn't do a degree, it was always a diploma. The degrees didn't exist, so I decided to do a master's, just to try and keep up with all the new physios coming onto the scene. And so I did a postgraduate diploma, and then actually went on to do an MPhil. And then as soon as that had finished, I went on to do my PhD. And by this time, I'd actually moved over to be the senior physio at Manchester United's academy, where I stayed for 10 years. And that was the research I did for my MPhil was all done at Manchester United, before moving over to Qatar and became the lead physio for the academy over in Aspire. And I was there for 8 years, which was a great experience. Now they're all preparing for the World Cup, and we saw many of the stadia being built, and they're absolutely magnificent stadiums. They're going to be part of the World Cup for next year. Came home a couple of years ago, and was helping as a consultant to develop an academy in India. So I was right over in India for quite a length of time before COVID hit, and that all sort of came to a standstill. And since then, spent time doing lectures online and marking PhDs and supporting students, etc. So bits and pieces of everything. So that's where I'm up to at the moment.
Wow, yeah. Perfect. What an amazing career, and like so many opportunities to travel the world as well.
Well, yeah, I mean, you know, sport has enabled me to sort of see all corners of the world, you know, from the, even, you know, with the academy at Manchester United, we travelled all over the world with junior teams, and obviously with the women's football, we travelled all over the world, and with the diving, the Grand Prix circuit was, you know, from Canada, USA, Mexico, over to China, Hong Kong, you know, and all over Europe. So yeah, I spent a long time in the air on aeroplanes from one reason to the other. Yeah.
And you mentioned these sort of double role of clinician and then more recently as a researcher. So I just want to ask you this question, because I know maybe some colleagues are thinking about doing some research and being more involved into the academic studies and research, but at the same time, maybe they don't want to give up on their seeing patients and being with athletes. So what's your advice on this?
I think you make a much better researcher if you've got some good clinical experience, you know, a number of years behind you, and can maintain a level of clinical involvement while you're doing the research. Because if you do that, then you actually know where the gaps are that need to be researched if you're interested in a specific area. And again, when I was at the academy at Manchester United, it was obvious there's a massive gap in knowledge and research around youth sport in general, not just football. Youth injuries, growth and maturity, there's huge gaps, and it still is. So if you're interested in a particular sport or a particular aspect of sport, if you've got that clinical knowledge behind you, it makes you a much better researcher, as I say, because you know what questions to ask and you know what clinicians are looking for. And so I think that helps. I think the other thing, it's not always easy to marry both roles. When I did my PhD, I did it full time when I was working at Manchester United, but the subject I was looking at was basically the role I had at Manchester United, so it was looking at youth sports. So that helped considerably, looking at an area that I was actually working in full time. But you know, I didn't have a family or children to look after, so you know, it was easier for me because it was just, you know, I could spend the time as I chose. It's not an easy role doing both, but certainly worthwhile at the end of it if you can stick to it. And it's just a case of working out your time and discipline with your time. But looking at a research that you're involved in on a day-to-day basis, so it's not completely different, and it's easier for you to manage. That would be my advice.
Yeah, perfect. And obviously you mentioned your PhD on youth athletes and the years that you spent at Manchester United. So my next question is about the growth-related injuries, and we know it's very sport-specific, but in general, what are the most common injuries that we see in youth athletes?
Well, saying sport-specific, I'm not too sure actually on that. I just think that some sports see a higher occurrence of some growth-related diseases, but all the growth-related diseases are similar. For instance, obviously Osgood-Schlatter's is a huge, you know, thing in professional football, but it's also quite prominent in young swimmers who swim a lot of breaststroke. And it's just the action of the knee, basically, where the you know, the big patella tendon joins onto the tibial tuberosity that you get in this irritation. So a lot of sports that have big youth programs, you will get these growth-related diseases, and and depends on when the sort of the more advanced training regimes start, would determine what sort of injuries you see the most of. So for instance, with football, we're seeing players, 8, 9, 10 when they join the academy, and we see there that the Sever's disease, which is where the Achilles tendon joins onto the back of the calcaneum, is very prominent at the younger ages, and then around about 14, 15, say, on average, it becomes the Osgood Slatters around the knee, and then 16, 17, 18, it's more the pelvic related. On the whole, I mean, obviously there are exceptions, but on the whole, you see that sort of groin related pelvic problem. And essentially what's happening is that the injuries are just following the pattern of ossification of the bone up the legs. So initially you get the first sort of signs of ossification around the foot and ankle. So that becomes very irritable when it's ossifying. So that's one of the reasons potentially why that you get this irritation at the insertion of the Achilles tendon on the calcaneum, where you've got a huge growth plate. And then around about 14 or 15, the tibial tuberosity starts to ossify and become more mature. And then the last thing to ossify in the lower limbs is the hip and pelvis. So, that's when these other groin related problems seem to be most prevalent. And all the research is showing that now. There seems to be a pattern sort of from the foot going up the leg into the pelvis. And so people say, oh, well, it's around peak height velocity. It's, where the biggest growth spurts are that these problems occur. And it's actually not quite true, because yes, it is for Osgood Slatters, but I think that's more of a coincidence rather than a cause, because, youngsters of 8, 9 and 10 are getting Sever's disease, and that's nowhere near the growth spurt. And then, boys of 16, 17, 18 and even above are getting growth related pelvic problems, and that's well past the growth spurt. So I think that the fact that Osgood Slatters is around about the growth spurts is a coincidence rather than it being a causative factor for it to occur. So
then what about the spinal injuries and stress?
Again, the spinal injuries, the more stress related, growth related spinal injuries around, again, on average, usually 14, 15, maybe 16. Again, it depends on the growth. That's when they tend to get those. And one important thing I would point out about the spinal injuries is if a young athlete, it doesn't matter whether they're a footballer or an athlete or basketball player, it doesn't matter. If you get a young athlete complaining about back pain, if that doesn't settle within a couple of weeks, it should be investigated, because young athletes don't tend to complain about back pain if they're trying to get out of training. Whereas, in adulthood, it's a great excuse to get out of work, to get out of things is, oh, I've got a bad back. If a young athlete wants to get out of training or is not enjoying it or is trying to avoid it, it's usually a lower limb problem that they will complain about. So if they do complain about back pain, it's usually because they've got back pain. So and if it doesn't settle with conventional physiotherapy after a couple of weeks, it should be investigated, because if you can catch these early stress related injuries in the spine, if you can catch them early, then they will settle down and you can resolve the problem. But if you let them linger and linger and develop and develop and develop, then they can then develop into a fracture, and maybe a bilateral fracture, which can take a year out of the career of a young athlete, which is the last thing that you want. So the earlier you can catch them, the more likely you are to get an early resolution. As I say, if they do complain and it doesn't settle within a couple of weeks, I would certainly, go forward and get it investigated.
Yeah, definitely. And you mentioned Slatter, and obviously very prevalent in young footballers. What does the literature say right now in terms of management of these apophysitis?
Well, as I say, the literature has got huge gaps, and there's not an awful lot in the literature specifically about Slatters. I would say that, and a lot of the problems in youth football with all these growth-related diseases is that there are no standard protocols. Like, there are lots of standard protocols to look after ACLs and various other things, but with things like Slatters and severs and these pelvic problems, there's no sort of accepted treatment regime. It's very much down to the individual physios to resolve. Again, one of the problems dealing with youth is that many of the players don't report the injury until it's that bad that it either causes them to limp and somebody notices the limping and then they question what's going on, or they themselves, feel it's just too painful to continue. And by that stage, it's difficult not to stop them from training, because there's no point in continuing them in training if they're either limping or in a great deal of pain, because that could alter the biomechanics, which could lead to problems elsewhere. So the key again is to try and educate both the parents and the athletes into reporting problems as early as possible. Excuse me. Because what you want to try and do is educate them into saying, well, if you can report the injury early, it may mean that you don't have to come out of training. But if you don't report it, there's every chance you're going to miss training. So it's to try and encourage them that not every injury means that they're going to have to stop training. And that's one of the big education factors I think is important with the youth, but it's getting it across to the parents as much as the athlete, because quite often it's the parent that's pushing them to continue training. If they've complained, they're going home after the game or a training session, so my knee's a bit sore, and the mums and dads say, oh, you'll be all right, carry on. Whereas, rather than saying, well, next time we're in, go and see the physio, see what they say, and we'll go from there. And that's what we need to try and do, is to get them to just get it checked out, and then the physio can say yes or no, or let's just have a very short break, and that might be sufficient to solve the problem, or no, we need to, it's that acute, we need to stop altogether. And that's I think one of the key things in dealing with these young athletes, whether it's Slatters or whatever, is getting them to report the problem early, so that we can have a better chance of resolving the situation without actually withdrawing them from training. Because not every injury you need to stop them from training. You just need to modify the training so that you're not irritating the problem. And quite often, if you just pull them out of any contact situation, so any game or any competitive situation, and just allow them to do the technical work, which isn't quite usually as intense, then it can quite often mean that they're allowed to stay into training because it's not irritating the situation. But you need the cooperation of the coaches as well to do that. So again, for me, one of the key things for a physio working in sport, again, whatever sport, is having a good, close relationship with the coach, so you can discuss these matters with them and the coach understands what you're trying to do. And many coaches in the past have just thought that physiotherapists and medical staff are a bit of a nuisance because they're taking people out of training, whereas we need to persuade them we're actually trying to keep them in training. We don't want to see them, really. We want to try and keep them in training as long as possible, but you can only do that with the coach's cooperation. So get the coach on your side and then educate the parents, who will then help to educate the the players or the athletes, and that is for me, almost as an important role as your ability to clinically deal with the injuries in youth sport, because they're so significant a part in the development of the athlete.
Yeah, I think for my experience, it's been very beneficial to do like education session with parents and coaches beforehand, before the season starts, and that set the tone for the rest of the season. And I think it helps massively the physios. Yeah,
and I think not just at the beginning of the season. I mean, obviously, if you're working with a squad, you need to, have good, close relationships with the coaches on a regular basis. Obviously, do more formal education sessions, but just have a good working relationship with them and keep them informed of any problems that may be developing, without obviously giving away all the medical implications, and you've got to obviously look after the athlete's personal data, if you like, but I think it's important that throughout the season you carry on with the education of the parents. Even once a month, have an education session with the parent. It gets them away from watching training, which they're all very, very focused on watching the training, and they're all experts. So you need to get them away from that sometimes, but also, introduce various aspects of, how they grow and develop, and, injuries and consequences of, etc. And I just, again, keep the parents on your side, and it'll make your life a lot easier in the long run, really.
Yeah, exactly. And then the other question related to what you said before, do you think there's a reasonable amount of pain, or how do you manage that if a player or an athlete reports a pain, for example, Osgood's?
Well, again, obviously everybody's, an individual, and some players, as adults as well as youngsters, can tolerate discomfort more than others. I think if a player can tolerate discomfort or pain, or however you want to describe it, to the point where it doesn't alter the biomechanics and their actions of the sport, and you wouldn't know that they were in pain if you're watching them perform, then, and they're comfortable in doing that, then I wouldn't pull them out of training. There's no evidence in the literature to show that, training whilst they've got a growth-related problem will lead to, problems in the future. There's nothing to say that. So if they can tolerate discomfort during training without any alteration of biomechanics, then I would say keep going. But be aware that if it gets worse, or you need to be monitoring these athletes very closely. So if you actually see any change in their running technique, or if you suspect there's a limp at all, you need to pull them out, and that's not because you think that, well, obviously it is getting worse to increase that pain, but it's so that you're preventing injuries from occurring elsewhere, because as soon as they alter the mechanics, it makes them vulnerable to injury in other areas. So that's the last thing you want. Mm-hmm. So if you get a good relationship with your athletes, and again the parents, then as long as they're aware that you're monitoring them and watching them, but allowing them to continue until there's a further issue, then I think everybody's happier, including the coach, because they've still got the player. And again, really, if the player is in pain, the best thing for me is your ice and your rest and your modification of things. I would never use electrotherapy on growing athletes, and something that I was taught 40 years ago, that ultrasound and a lot of this electrical instrumentation is not always favorable, particularly around growth plates and things like that. And then I can remember an old tutor that was involved in rugby always used to say, you know, your hands are your best piece of equipment, because there are no plugs in the middle of a football pitch or rugby pitch, which, you know, is great advice. You know, many a time as a physiotherapist, particularly when you're traveling with teams, you haven't got the backup of all this electrotherapy because you just can't carry it with you. It's just too much. So you have to learn techniques manually, and you have to, you know, modify training. You have to use ice and massage, you know, to help in recovery and do proper recovery and warm-ups and things to alleviate some of these problems. So, you know, don't be relying on electrical therapy, particularly in youngsters, but ice, rest, modification of activity, maybe taking them out of literal football but putting them into something else, maybe swimming or you know, other areas that are not, you know, aggravating the whatever the problem is, but trying to keep them as fit as possible. But bearing in mind that, you know, sitting on a static bike to maintain fitness isn't the same as running. There's you know, quite often you get people, oh, I'll sit you on the bike for half an hour, you know, that'll keep your fitness going, but it isn't running fitness. It'll keep a modicum of fitness going, but it's not the same actions as if you're running. So you need to be careful with that. And this is where you know, people have had a massive advantage with pieces of equipment like an Alter G, which obviously, you know, would help greatly. And that was something that we used to use at United a lot. Obviously we could afford to have one, but for me it was a massive piece of equipment as far as allowing people to get back running much earlier than they would have done if we hadn't had that, and obviously much better than them sitting on a bike, you know, as far as actions are concerned. So that's where, you know, things have improved massively, and even things like, you know, we had at United an underwater treadmill, which was valuable, you know, for us. I mean, the first team used to use it during the day, and then we had the academy in the evening and used it then. So it was fabulous for us, you know, and very useful, apart from the very small ones that couldn't reach the bottom. But no, it was you know, things like that. That's where I've seen massive improvements in your ability to keep somebody going as such in the correct sort of action, you know.
I think that's it's a great advice. Thank you very much. And I think you mentioned monitoring the load, and I think when you work in a professional environment, with your athletes full time, so you know their internal load, you know their external load, and it's much easier to monitor the load through the week. But then as a clinician, maybe you're in your clinic and you see a patient for half an hour and you asked, okay, what to do? Can he train? And you need to make a decision about monitoring load. Are there any strategies for monitoring load when you don't have many objective measures?
I think more than monitoring load, I think what's important to understand is the most important thing to monitor in a growing athlete is change of height, more so than load. So it's important that, you know, even if you're working in a clinic and you're not seeing the person on a daily basis, you can get them at home to take their height on a monthly basis. And that, again, there's a bit of literature coming out now that's proving more and more that it's the change of height whilst they're actually doing a training sessions, you know, on a regular basis, a heavy load, that creates the problem, because of the imbalance of mechanics and strength that change and flexibility that change when you get this sudden spurt of growth. So it's important that if they keep a monthly growth chart. And if you're working in a club on a full-time basis, you should do this anyway, whatever sport you're in. So a monthly height chart. And if there's any alteration, even a small alteration in height, that needs to be flagged up to the coaches. And then those athletes should be monitored more closely as they're training over the next few weeks. So it's not so much, you're not so much altering the load so much as just watching them. And if they start to struggle, or if their performance drops, or if they look fatigued, that's when you pull them out and maybe give them extra rest sessions, maybe tell them to miss a couple of sessions that week if you're in the academy, and monitor it that way. And it depends, really. It depends on, you know, what sort of load they're doing in the sessions. Is it a technical session, or is it more of a, you know, a fitness session? And but by monitoring the height change on a monthly basis, that is the biggest red flag, if you like, for injury in a youth player that can be seen at the moment. And that's something that everybody can do, whether, you know, you don't need any fancy equipment to do that. I would just say, if you are measuring height, be very careful about using cloth measuring tapes, because they do stretch. So quite often just using a metal tape and fixing it to a wall or something and leaving it there, and then people can check it on a regular basis. You don't need any fancy equipment to do that. So even at the lowest level, you know, that can be done. And as I say, there's more and more research coming out now that's saying that when there's a change in height, that's when these injuries are occurring. So you know, it's a simple enough thing to follow.
Yeah, exactly. And then the last questions for today is more about communication. We know sometimes could be challenging to communicate with young athletes, especially teenagers, and then communicate with parents as well. So do you have any tips on that?
I think again, if you can get the communication strong between you and the coach initially, and then you and the parents, then that gives you a good background, because if the parents understand where you're coming from when they're talking to their child, they will do it in a positive way towards you. But I think one of the big things about dealing with youngsters is having a bit of fun, and that's where you get the best sort of communication, is having some fun, having let them have a laugh. Don't be frightened of being laughed at every so often, but make sure it remains respectful. You don't want them to be running all over you, but having a laugh, but also listening to them as well. Don't dismiss them. Quite often I think that youngsters feel that people aren't listening to them, particularly, you know, coaches and quite often parents, if the parents are very pushy and determined that the kids are going to, you know, be the next superstar, and quite often they're under a lot of pressure, these kids, and if you can just sit down sometimes and just have a chat with them about, you know, how they're doing at school, you know, just on subjects, you know, even daft things like pop music. I can remember once doing a rehab session with kids, and none of them knew who the Beatles were, and of course that's who I grew up with, you know, so we had a big laugh about that, you know, just things like that, just making it, you know, fun and you know, but also always listening to them, because quite often I feel that a lot of them just, you know, don't know who to talk to, and because in a rehab session you're spending so much time with them, you need to listen to them then, because that's when they're at the lowest, because they're injured, they're not with the friends, you know, the parents might be on the back, the coaches might be ignoring them, so they need to have a friend, if you like, and I think that's important, and it's an important role for physios of any age, you know, that they're dealing with any age athletes. You know, quite often athletes can get very, very low, and the physio is the best person for them to unload on and let them and then you get a better understanding from where they're coming from, you know, or maybe how to push them forward and, you know, in which direction, etc. So it's just being a good listener, having a bit of fun, but with children particularly, getting good communication with the parents and allowing them to, or make yourself available for the parents to talk to when they need to as well.
Yeah, perfect. That's great advice. Thanks Amanda. Thanks very much for your time today.
No problem at all. I enjoyed it. Thanks you.
And we hope to see you soon on Guida Galattica per Fisioterapisti.
Okay, anytime. Thank you very much.
Thanks.
Thank you.
And thanks everyone for being with us today, and we hope to see you soon on a new episode of Guida Galattica per Fisioterapisti podcast. Goodbye.
Bye.